Hi, and welcome to AAHPO's American Armenian Health Professional Organization's TV Health Program. We're again today having Dr. Aline Herlopian. She's assistant professor at Yale University at Department of Epilepsy. We are continuing the conversation about epilepsy and treatment. We left at the treatment, so we were going to discuss the treatment at the same time, other factors of the epilepsy that can affect people's life. Dr. Herlopian, welcome again, I should say.
Thank you.
Let's continue our discussion that we left last time, and let's talk about the importance of the family members and or the patient's surroundings or other people knowing the person that having seizure, because when seizure happens, at least they should know what they do. What is the first aid of that, or what they should know?
Sure. So when seizures happen, the most important is to make the person who's having the seizure in a very safe environment. So what that means is if the person is having the seizure and they're standing up, suddenly they stopped and they started to have this stiffening where their arms goes straight forward and they're at the risk of fall, the family member has to make sure that they lay them on the floor on their side, which means one of their shoulders lying on the lateral side, and to make sure that they don't have the eyeglasses or there is nothing around them that might harm them or cause any injuries. Now, that being said, there is the whole myth when people say they swallow their tongue, right?
Right. I think what we should say first is that what they shouldn't do.
That's
the most important thing.
Exactly.
Instead of really what they should do, because they do the wrong thing first. That's not good.
Exactly.
So what they shouldn't do.
So they should not put any object in their mouth.
Right.
They should not try to pull the tongue out.
Because they cannot swallow it.
Exactly.
Right.
Because the tongue is never swallowed.
Yes.
What happens is that when people have seizure, they go into stiffening, right? So they tighten up. Right. So their jaws are so tight that what happens is they start biting on their teeth and their tongue. Yes. So if you are trying to pull that tongue out, they're going to bite your finger.
Right.
So that's not a good job. So what you do is just you leave them where they are, just to make sure that they're not
hurt. On the side.
Exactly, either side, and they're not harming themselves, which means that they're not sort of like banging or flailing their arms into the glass or whatever. Now, the other part is why do we put them on their side? Is because sometimes when people have seizures, they start gargling or they start swallowing their secretions or they throw up. So you don't want them to aspirate. You don't. If they aspirate, they go end up in a pneumonia. Right. So you do not want that. That's why the safest way is to make sure they're on their side, and the seizure on its own is going to last for like a minute and it's going to stop. Now the problem what happens is when you ask the families how long did the seizure last, they tell you 5-6 minutes.
Because they last
exactly.
Seems that
exactly.
Is that long.
Exactly. So they panic. So it's very known that it's a very disturbing experience for people to see someone is seizing their beloved family member or a friend, but whatever this happens, the seizure, it will stop on its own. Now, what they can do is they can start timing. Right. The reason for the timing is if seizures truly last for more than 5 minutes, this puts them into a category. Exactly. Right. So that is a prolonged seizure, and that harms the brain and has poor prognosis, poor mortality and morbidity. So you want to stop that at the earlier on. So that's why it's important for them to have a correct timing of the event.
So really then the person immediately should be assisted if they didn't fall already.
Exactly.
So they're on the floor.
Exactly.
To the floor, on their side, don't touch to the mouth.
Exactly.
Don't put anything in the mouth.
No.
Don't pull anything from the mouth.
No.
And then if they can support probably the head, if
exactly.
They're shaking the head and banging.
Yeah.
There might be something with support and wait until the seizure passes away.
Exactly. And this is just for the convulsion. Whereas as we were talking earlier in the other program about the focal seizures, sometimes when people are standing up or let's say they have the seizures of they cannot talk or they hear you but they cannot respond or they're just like silent and doing nothing but picking on items, you just leave them on their own, make sure they're safe, make sure they're stable. You don't need to put them back on the floor because that might agitate them. Exactly.
They are alert already.
Exactly.
Yes. But they are not alert, but they're not really communicating.
Exactly.
The communication is not there, but they are alert.
Exactly. So their awareness is altered.
Right, right. So there are some triggers that can happen actually to start the seizure, like alcohol, let's say. What are the important things that you think that it triggers the seizure, and people should know?
So we call these triggers or provocative factors, and there are several of them. One of them, the main one, is alcohol, which lowers your seizure threshold. So, and the other factor is when you have epilepsy and you're being treated, alcohol interacts with other medications. So it's a two-way. Exactly. So it harms you in both ways, either by interaction of medication and also by lowering your seizure threshold. So alcohol consumption is not a good idea.
For epileptic
exactly. For example, sleep deprivation unmasks or can lower also the bar of the seizure.
So they need really enough sleep for them not to get the seizure.
And actually one of the recent studies and the research has already emphasized on sleep apnea. So if you see lots of people in the old category, in the 50s, 60s, they have sleep apnea and it's untreated. And that causes disrupted sleep. They don't wear their CPAP, they have disrupted sleep, and they go into breakthrough seizures. So that is important for them to treat.
So good night's sleep is
exactly.
How about stress? Stress has to do a lot with the seizure.
Exactly. So stress is another factor for people to go into seizure, and we have to here to differentiate between seizures that are because of stress and they are not because of the brain is triggering the epilepsy. And there's another seizure where it's the person truly has epilepsy, but under stressful situation, including infections, travel, the exams, exactly, can trigger the epilepsy. So we have to make that distinction as well.
Yeah, exactly. So as long as obviously you as epilepsy specialist and then we as a primary care physician, we have to inform them what triggers are there, and they really should be aware of those triggers and they should be aware. So let's talk about now treatment. Now we have epilepsy, the patient is diagnosed with epilepsy and comes to you, and there are so many medications now that are approved. Could be surgery, could be other. Let's talk about medications first. But before that, I think I remember something to say. There are certain medications that actually can trigger. I forgot that. That certain medications, not antipsychotic, I should say, but antidepressant medications can trigger the. Family physician has to be aware of them too. Because that's not neurologists will know, but not the other. Might not be.
There are lots of medications from antibiotics, from antidepressant that interacts with the anti-seizure medications.
Usually, do you give the list of the medications to the patient? Say, keep this. If you see a family physician, if in case one of these are given to you, inform them that this might interact with my medication.
Exactly. What I do is to simplify it to them, I tell them whenever you're about to take a new medication, give me a call.
But it might be a little difficult. I think I will do probably just say, here's the list. If one of these are given to you, tell them that it's not, and you can call me.
Yeah, you're right. I mean, it depends in what way you'd like it. Now that you have the in-basket and the My Chart, they can easily email you. And then you can
So let's talk about now actual treatment for epilepsy. There are a lot of medications. How do you choose medication and which patient?
Okay. So as far as for the treatment, the first way to approach epilepsy, again, as I said, you have to say, is this epilepsy and is this going to recur? And that's when you start the treatment. Now, once you have that yes response, you start classifying, is this a focal epilepsy or is this a generalized epilepsy?
And then usually we do the EEG, let's say.
Exactly. So when we decide to have the patients on treatment, we have to dichotomize focal or it's generalized.
And it's done with the EEG already.
Or sometimes history also. When the pediatric person, when the patient comes and tells you, I just stare and come out of it easily, that's likely an absence seizure, and it's in pediatric. So when you have that, there are specific treatments that are for focal and specific treatments that are for generalized epilepsy. And sometimes in generalized epilepsies, there are medication that makes it worse. So you have to be careful about these tricks there. So when it's focal, you have the list of medication you can try, and when it's generalized, you have another list of medications. And there are medications that can cover both focal and generalized. So you start with the medication. The choice of the medication is very arbitrary. There is no first line, there is no second line.
In the past, we said Dilantin is the first line of the treatment, but it was in the past, obviously. Now, I'm sure it's not the case.
It's different. So now what you decide as, first of all, you have to take into category, for example, if it's a woman or a man. Because in case of the woman, one of the anti-seizure medications that can cause some problems for women is valproic acid. Because if women are going to become pregnant. It causes problems with the babies. It can have side effects, malformations. So you want to avoid that. So there are other medications that are safer in women, like levetiracetam, and those you can start it. It's safer to use them. Now, when you pick or to start choosing the medications, that's when you start to say, is it going to respond or is it not going to respond? And the response rate depends on the seizure frequency. For example, if you have a person who seizes 3 times per week, so your response rate should be in 3 weeks' time, how many seizures did they have? If they had in 3 weeks' time 1 seizure, that's a good response. So then you start adjusting the medication. And usually it's 60% success rate with the first anti-seizure medication.
And most of the time patients are informed anyway. So
Exactly.
we'll be trying so many medications for you, but finally we'll end up something that, don't worry, we'll find what is good for you.
Exactly.
Right.
And then there are sometimes also, for example, in the elderly population, you have to make sure you don't give them medication that might cause their sodium to drop, or interact with, if they're on Coumadin, or interact with Coumadin. So you have to judiciously choose your medications.
Exactly. So it's going to be tailored, actually.
Exactly.
In the past, there were a class of medication that it was used first, but it's not anymore. Like we do in high blood pressure, we tailor now. It's
Exactly.
not first line, second line, third line. So patients should know that, okay, we are going to try certain medications, but we will find something it's good for you.
Exactly.
Yes.
So there are lots of medications, many of them actually. So you can just, it's a trial and error. There is no right or wrong. Some people in even the specific type of epilepsy might respond to one medication, whereas the same person might not respond.
There are obviously complicated cases that you have to really combine so many medications finally. But let's move away from the medications. Let's talk about other options, because let's say if really a persistent seizure or epilepsy is coming on, we have surgery in the picture.
Exactly.
We have probably some devices.
Exactly.
Let's talk about surgery first.
Okay. So the guidelines for surgery is there are 3 main points they have to satisfy for them to be a candidate for surgery. Now, when we say surgery, this doesn't mean we're putting them on the wheelchair and now you're going to the operating room.
Right.
It's a very long process. It usually takes about a year time frame. And in that time frame, we study the patient's epilepsy.
Right.
It's dedicated study of the brain. So what we do is usually, and the way we say it's time for us to study your epilepsy is when they fail at least 2 anti-seizure medications. And when we say they fail, it's not the side effects. It's the response they have failed at.
Less, and
exactly.
they have still seizure going
Exactly. And the person has to tell you, I'm disabled from my seizure.
Right.
So if they're not disabled, they're fine with it, then it's up to them. But if they are disabled, then that's an indication to start a surgery.
The process starts.
Exactly. So the process, the way it works is, first of all, the physician and the patient have to have a communication and sort of a good in-depth discussion about what this entails, because the person has to be away a bit from work, they have to stay in the hospital, they have multiple tests to do. So it starts by admitting the person to the hospital and having them a seizure there.
Tests, right?
Exactly. So the person has a seizure, and the idea of them having a seizure is to say where the seizure is coming from. If it's one side of the brain, exactly. So once we have that data, and once we have the MRI and the PET scan, we sort of like put them all together and say, is this person a candidate for surgery or not?
And the neurosurgeon comes in the picture
Exactly.
for the surgery.
Exactly. Now, sometimes it's hard to localize where the seizure is coming from. For example, sometimes we know more or less it comes from an area of the brain, but that area is very broad. You have to narrow it down because you cannot cut that whole part. Exactly. So that is when we start doing the more invasives, when we start implanting the patients with a more detailed electrodes to see where seizures come from.
Before we finish the program, because I know we are running out of time, I want to know and then inform the patients about the driving. Now, they have the seizure, and always question comes in, can I drive? I cannot drive. Why I cannot drive, and how long? That's the question.
Okay.
So we have an epileptic patient, comes to you now, and what do you tell them about driving?
Okay, so for driving, to start with, the driving is different from state to state. There are different rules and regulations. There are only 6 states, including California and New Jersey. They want the physician to report to the DMV.
Okay.
The other states, you do not report to the DMV. That's one of them. The second rule is the time frame that you have to be seizure-free for you to start driving.
What is the time frame?
So the time frame is anywhere between 3 to 24 months, and there are states where they do not give you a time frame. It depends on the physician's discretion. For example, there are people who have seizure every week. and then you know that they have been seizure-free for 2 months, then in those states you can say it's fine for you to drive.
Because the frequency is a lot.
Exactly.
The time is okay, enough.
For example, there are patients who you know they have a cluster of seizure every 4 months. So when they fulfill the 3 months time frame, you know in the fourth month they're going to have a seizure. Exactly. So you, at that point, you tell them the law says this much of seizure, but then you would tell them that I would like you to have more time when you're not driving.
Dr. Herlopian, thank you very much for this informative information. We'll hopefully invite you another time for other topics.
Thank you.
Now it's time for this week's article. It is alcohol consumption and risk of colon cancer. Colorectal cancer is the third most common cancer diagnosed in both men and women in the United States. Several lifestyle-related factors have been linked to colorectal cancer. Overweight and obesity, physical inactivity, high intake of processed red meat, and smoking increases the risk of colon cancer. Alcohol consumption is an established risk factor for colon cancer. Genetics play a role in the development of colorectal cancer. Individuals with family history of colon cancer is more susceptible to adverse effect of alcohol consumption. Recently, Dr. Cho and colleagues investigated whether the association between alcohol consumption and colon cancer risk differ by family history of colon cancer. They conducted a prospective study among more than 87,000 women and more than 47,000 men, and follow-up was 26 years. They found that higher alcohol intake, more than 30 grams alcohol a day, was associated with elevated risk of colon cancer. The association between alcohol intake and colon cancer was stronger among those with positive family history of colon cancer compared to among those without family history. Also, folate deficiency, in addition to alcohol consumption and family history, further increased the risk of colon cancer. In conclusion, they found that alcohol consumption was associated with elevated risk of colon cancer, especially among those with positive family history. Association was significant for more than 30 gram alcohol intake a day. So what is 30 gram of alcohol? Well, more than 2 cans of beer, or 2 glasses of wine, or 2 shots of any hard liquor contains more than 30 grams of alcohol. Reducing your alcohol consumption will decrease your risk of colon cancer, especially if you have family history of colon cancer. Good health is precious and priceless. Keep informed. Visit AAHPO's website for up-to-date information, aahpo.org. I'm Dr. Ohan Karatoprak. Until next program, so long.